Behind every good system is a good paradigm. A paradigm is your focal point. It's the thing that you keep coming back to over and over, like a trusted friend. And it has all of the answers that you need. I'm going to share with you right now the treatment paradigm that I've been using for over 15 years. And it is the paradigm embedded within the TxPro system. Let's begin. Every patient or client that walks through the door is like a scale. And when we evaluate this person, we're looking on both sides of that scale, the front of the joint and the back of the joint, this muscle versus that muscle. It's very Zen or Taoist in its approach, in a sense that we're looking at the yin and the yang, two opposing forces that are working against each other to maintain the body in homeostasis. We all learned homeostasis back when we studied biology in grade school or high school. But from a neuro-orthopedic perspective, what is homeostasis? Well, it is the balance between mobility and stability. And that is at the center of the TxPro paradigm. I'm going to define these two terms for you quite simply. Mobility is the ability to move. Stability is the ability to resist or control movement. And it's these opposing forces that maintain the body in balance as we go about our day-to-day activities or our sports. If you are trying to get a patient better, you have got to balance these two opposing forces within the system. Because if you treat the system as a whole, then you can treat the symptom. So the slogan would go, balance the system and treat the symptom. So here's how it goes. Mobility can be broken down into one of three primary categories. The first and most important is nerve. The nerve takes priority. Nerve mobility confounds countless numbers of therapists. When a patient has difficulty going into abduction of the arm or touching their toes, it's too easy to think that this is a muscle or a joint problem. Almost every single time, undergirding that problem is some sort of nerve mobility deficit. So the nerve is top priority when we're looking at mobility. The second piece is the joint. So if we have a mobility deficit, so if we have the inability to move, joint mobility problems may be restricting that. It seems rather obvious, but throughout this system we're going to be delineating between, is it a nerve mobility problem, a joint mobility problem, or lastly, a muscle mobility problem. Now you might be asking yourself, where does fascia fit in here? Well, fascia is everywhere. So because fascia is everywhere, you can think of fascia as being in each of these different components and surrounding them. Now there are a couple of structures that don't appear here, but their presence and their ability to resist movement is relatively infrequent. The skin is a good example. So when we have superficial fascial adhesions from a surgery, like a scar that's adhered down, sometimes that can be creating some mobility problems, and that would be a fascial mobility problem. But in general, that's pretty obvious. When we're looking as a differential diagnosis to figure out what's wrong with the patient, we're looking at nerve, joint, and muscle. And we're trying to figure out where is the mobility deficit within these three tissues. Now, opposite mobility, and equally as important, are your stability deficits. And we'll break those down into three categories that relate to everything on this side. Relating to nerve is our motor control. Now your motor control is your ability to turn muscles on and off, the timing of the muscle, the amplitude of the muscle contraction, the sequence of the muscle contraction. Now this is primarily controlled by the brain, but the spinal cord has its own memory for this. Like in gait, when we walk, the spinal cord controls most of that pattern. So you can think about the motor control as what is the predetermined motor plan that's in the brain. For instance, if you watch a ballet dancer bend over to pick up a pencil, or throw a frisbee, there's a certain movement pattern that they exude. There's a certain elegance to the way that they move. Now, throwing a frisbee, we all do it and we all do it differently. But when you watch a ballet dancer do it, you can almost identify, hey, that person's a ballet dancer. Because their motor control, their motor planning has been trained over many, many, many years to have a certain engram to it, a certain pattern. Now, of course, that pattern has flexibility and variability. If you put that person in that same movement over and over, you're going to see variability in that movement, but it all looks kind of the same. The joint, on the stability side, we're looking at tissue integrity. Does the joint have its own stability or tissue integrity? Now, if you think about it, if I sprain my ankle and I roll it really hard and I stretch out my anterior talofibular ligament, my ATFL, and now that ligament is loose, just like pulling open the collar of a sweater, and that sweater's loose. Well, now we have a tissue integrity deficit, which means the joint complex itself does not have the same integrity that it once did. And that's going to create a stability problem. That joint is going to have a harder time resisting motion. If I tear my ACL in my knee, that joint's going to have a harder time resisting anterior translation. And so, over on the stability side, the ability to resist movement, the next most important piece is tissue integrity. And then lastly, corresponding to muscle, is strength. You need strength to resist movement. You need strength to create movement. But more often than not, it's not the inability to create movement that gets us in trouble from a neuro-orthopedic perspective. It's the ability to stop movement from occurring, excessive movement, like a Trendelenburg when you stand on one leg and the opposite hip drops. That's the inability to stop movement from occurring. Well, is that a motor control problem or a tissue integrity problem? Maybe, but it can also be a strength problem. You see, here's the thing. If you think about it like driving a car, if you're driving up a really big hill and you have a car with 50 horsepower and it can't make it up the hill, it doesn't make a difference if your car is well put together and you've got great driving ability. It's not getting up the hill. If you don't have the strength to accomplish something, it's going to look wrong. You can train motor control, but without strength, that car is not going anywhere. So think about it. Tissue integrity, the build of the car, motor control, the driver, and strength is the engine, what's under the hood. Stability is the ability to resist movement, and it requires all three things. So when I'm looking at a patient, I'm examining them, and I am trying to figure out what's the problem. The first question I'm asking is, am I looking at a mobility problem? The inability to permit movement? Or am I looking at a stability problem? The inability to stop movement? Or is there too much excessive movement in a way that I don't want? Now, sometimes patients come in and the primary feature of what's going on with them is pain. Pain, swelling, or inflammation. If a patient or client comes in with pain, swelling, or inflammation, you can't even assess any of this. They're not going to show you what their strength is because the test hurts. They're not going to show you clean motor control. They're going to show you altered motor control simply because they're in pain. Tissue integrity, it's kind of hard to tell. You can't do accessory motion testing or special testing when there's a lot of pain because you can't get to the end field. The end field is what we say is empty, meaning it's a painful end field. So overgirding this entire process is pain, swelling, and inflammation. If a patient or client comes in with significant pain, swelling, or inflammation, that has to be treated first. If you don't treat pain, swelling, or inflammation, and you try to strengthen somebody, or you try to do a nerve mobility technique like flossing, or you try to mobilize the joint to increase the tissue length, you're not going to do very well. That patient will get more inflamed and be in more pain. So when pain, swelling, and inflammation is present in a way that overarches and collapses this entire system, it needs to be treated first. And then lastly, undergirding the entire paradigm are your contextual factors. Now, contextual factors, we all know, are part of the ICF model for those of you that have learned that. But think about it this way. I can fix your neck, but if you don't stop slouching, the pain's going to come back. The way to think about that is if you're 7 feet tall or 8 feet tall, and every time you walk under a doorway you hit your head, and you come into the doc and say, "Doc, I got a headache." The doctor gives you a couple aspirin, a headache goes away. When you go back and you hit your head again, you come back and you say, "Doc, my headache went away, but it's back." Well, that's because you keep hitting your head. I mean, it's obvious. If you don't resolve the contextual factors, if you don't stop a patient from making themselves worse, then none of this matters anyway. You got to stop stubbing your toe to make your toe feel better. You got to stop scratching your scab before it heals. There's many analogies or ways to explain this to the patient or client. So contextual factors are key. You have to solve the contextual factors before you have access to treating mobility or stability problems. Because if the person goes right back to the habit that's creating the problem, homeostasis will not occur, balance will not occur. So when we are treating, the beauty of this paradigm is it tells you how to proceed. You proceed from the outside in and from left to right. You have to resolve pain, swelling, and inflammation first if it's interfering with your ability to treat anything inside. And you have to address contextual factors. I almost always do it on session 1. Once you get inside the grid here, then you work from left to right. You clear out your mobility problems first, and then your stability problems next. An easy example of the reason why to do that is if I lack hip extension, as I go into my terminal stance in gait, if I don't have hip extension and I need to get myself to the end of that gait cycle, I'm simply going to produce an anterior pelvic tilt to do it because I need the motion. And you can strengthen the living daylights out of my abdominal muscles, but I'm just going to relax them in order to get my hip behind me and get that anterior pelvic tilt. The great Shirley Sarman once said, just because you're wearing a muscle doesn't mean you're using it. So you can build the abdominals all you want, but if you don't have hip extension, that abdominal strength is going to do you no good because your motor control is going to shut it off in order to get the mobility that you don't have. So we go from outside in and from left to right. Now the cool part is, for each of these problems, there are associated treatments that target that particular part of the impairment model. So for instance, if we're trying to improve nerve mobility, we have our myofascial techniques to release the nerve. We have nerve flossing or gliding. To increase joint mobility, we have accessory motion, physiological motion, oscillatory, sustained, all of our joint moves. We can even do soft tissue therapy around the joint complex itself. To create muscle mobility, we have stretching techniques. We have passive, we have active, we have resistive. There's a lot of different techniques to improve muscle mobility. We have soft tissue release. Over on this side, when we have motor control stability deficits, we have our neuromuscular reeducation, our facilitation techniques to treat tissue integrity, taping, bracing, and orthotics. I mean, if your arch is collapsed and it ain't ever coming back and it's causing your knee to collapse in when you load, you need an orthotic. And there's nothing else that you can do about it. It's kind of too late. That's a tissue integrity problem of the plantar fascia. Tape, brace, orthotics, the 3 primary things to address tissue integrity deficits. Over on strength, well, that one's easy. I mean, strength is something we're all pretty familiar with. We have isolated techniques, integrated techniques. And there's a whole host of different things regarding strength. In fact, there's an entire paradigm around this strength deficit. For pain, swelling, and inflammation, what do we have? Well, to treat pain, of course, you have medication, but we also have things like electrical stimulation. We have light massage can treat pain. Touch can treat pain. We have many different modalities that just treat pain. Kinesiotaping can treat pain through the gating cycle, the gating system. Swelling, well, we have compression. We have retrograde massage, lymphatic drainage, ice, inflammation, same idea. And then underneath here, contextual factors, well, that's our behavior change facilitation. which is an entire module unto itself, is getting people to change the behaviors that are potentially making them worse. TxPro contains within it this paradigm. This paradigm is the center of the wheel. It's the hub. It's the thing that holds it all together. If you understand how to use this and how to break down a patient's or client's impairments within this paradigm, then you can treat anybody. And every time you learn a new technique, you know exactly where it goes. If I show you a Graston technique where I'm lengthening tissue while Grastoning the muscle, you know where that technique goes. If I'm going to show you a stabilization technique, you know where that technique goes. I hope that all makes sense to you, because this right here, this is it. And then when you examine the patient and you find those impairments that you find live within this model. So if I'm watching somebody walk and I see the toes turn out and I check their ankle dorsiflexion, I'm going to put ankle dorsiflexion as a joint mobility deficit. If I then check their posterior tibialis muscle and it's weak, I'm going to put that right here. It's a stability strength deficit. If I then ask them to stand on one foot and they're unable to stand on one foot and it's a big mess, that's a motor control deficit, probably sitting on top of a mobility deficit at the ankle and a strength deficit at the foot-ankle complex and at the hip. If I take a look at a shoulder that's a little bit swollen, well, that's up here. Every single time that you evaluate a patient or a client, we're going to write out each of those impairments and categorize them in this model so that you can see very clearly. And then, what do you treat first? Well, it's easy. You treat from the outside in and from left to right. If they have pain, swelling, inflammation, treat it. Contextual factors, treat it. If they have nerve, joint, or muscle deficits, treat those first. Go from left to right. Then go over here and address the stability deficits, both between sessions and sometimes within session. So that's the TxPro paradigm. And we're going to go through it with a couple of patients, and we're going to see how it works. And as we learn techniques, we're going to keep referencing this paradigm because it's at the center of everything. So stay tuned, because there's more stuff to come, and I look forward to treating with you. Thanks so much.